Hello, my name's Lou Milanese, and what I'm presenting today is exercise-induced bronchoconstriction and exercise-induced asthma. The goals of this presentation. At the end of this presentation, I want you to be able to differentiate between exercise-induced asthma and exercise-induced bronchoconstriction. I want to be able to identify those who are most susceptible to exercise-induced bronchoconstriction. Want to know the pathophysiology of exercise-induced bronchoconstriction? This is where I spend most of my time because I believe firmly that we got to know how it works before we can attack it. Fourth, we want to know the challenge tests that can be performed to determine if there is hyperreactivity of the airways to exercise. And fifth, we want to know what treatments are available for exercise-induced asthma and exercise-induced bronchoconstriction. Let's talk about the difference between exercise-induced asthma and exercise-induced bronchoconstriction. Exercise-induced asthma, as you can see here, are symptoms of asthma occurring after exercise. These are people that have a diagnosis of asthma and exercise happens to be one of their triggers. As we can see by this next statement about asthmatic subjects, 75 to 80% of them have exercise as a trigger. Does this mean they don't have exercise-induced bronchospasms? No, they do have exercise-induced bronchoconstriction because exercise is a trigger. Now, if we look just at exercise-induced bronchoconstriction, that is the reduction in lung functioning happening after exercise as observed after an exercise test. It's the temporary contraction of the respiratory muscles after exercise that happens frequently in subjects, even with those not having a diagnosis of asthma. Next, let's talk about what is exercise-induced bronchoconstriction. It's the transient or temporary narrowing of the lower airways, that's where this occurs in the lower airways, occurring after exercise. Occasionally, it can occur during exercise. It occurs mostly in patients with recognized asthma, but remember, it can also occur in those without signs of clinical asthma. We see this a lot in elite athletes. What are the symptoms? Well, our big four that we see with asthma: coughing, wheezing, chest tightness, and shortness of breath. And also there's excess mucus production, and you'll see why as we go into the pathophysiology of this. Why test for exercise-induced bronchoconstriction? Found this interesting. Approximately 50% of the elite athletes reporting symptoms during exercise have no airway narrowing, and also about 50% reporting no symptoms will test positive for exercise-induced bronchoconstriction. So now let's talk about who are most susceptible to exercise-induced bronchoconstriction. Endurance sports, soccer, basketball, lacrosse, certainly runners. Cold weather athletes like cross-country skiers, ice skaters, mainly hockey players, figure skaters, and we'll see this in speed skaters as well, and swimmers. Swimmers confuses a lot of people because we think of them as being in a warm, moist environment, and we're not really drying or cooling the airways. But what happens is there is a warm layer of air above the surface of the water, and that is a trap for bacteria and pollutants. So it's not necessarily chlorine, because we see this happening in swimmers that are in non-chlorinated pools as well. Okay, now that we've talked about those that are most susceptible, let's start the pathophysiology part of this presentation. First of all, we're going to start with a brief review of our airway epithelium. Now remember, we're focusing right now on the smaller airways, because those are the airways involved in exercise-induced bronchoconstriction and exercise-induced asthma. So our first cells, starting from the top, are our ciliated cells. At this level of the airways, we're probably talking about cuboidal cells. And you notice they have the cilia at the top that beat back and forth very rapidly to move the mucosal layer, that yellow layer above, that mucus layer. And what it does, it moves it closer and closer up to the throat where it can be expectorated. This is part of what we call the mucociliary escalator. The blue cells next to them are Clara cells or club cells. These are involved in the body's defense mechanism in that they secrete a cytokine of Clara cell secretory protein that does a few things. One of the things that it does is it enhances the secretions from the goblet cells. And we'll talk about that in a little bit. There's a protective layer of mucus that they cause the goblet cells to produce. We also have the goblet cells, and we just talked about them. Those are the main cells producing mucus in the airways, replenishing the mucosal layer. We have the basal cells. These are progenitor cells in the airways, and we're going to see as we go into trauma to the airways, where the epithelium is broken loose or destroyed, these progenitor cells end up becoming or transforming into those cells as replacement cells. It's kind of like your body's repair mechanism. And the pink layer at the very bottom is the basement membrane. So what do we know about exercise-induced bronchoconstriction and exercise-induced asthma? The longitudinal studies, now this is where one patient, one subject goes through all phases of the study, not only being the control, but being the one that is being tested as well. These studies have shown that airway hyperresponsiveness to both exercise or cold air at an early age is a very good predictor of persistent asthma. So we find this in patients with EIB. They have epithelial disruption or damage. We see this after exercise of some of the epithelium being washed into the airways. Increases cystinoid leukotrienes. These cause goblet cells to produce more mucus. They also cause a very intense bronchoconstriction of the bronchial smooth muscle. And the other thing they do is they cause vascular leakage, permeability of the capillaries, causing edema. Mast cells and eosinophils are definitely involved. And there are increased levels of phospholipase A and transglutaminase 2. These are two cytokines released by the epithelium. Transglutaminase 2 enhances what phospholipase A2 does. Okay, so let's talk about what A2 does. Phospholipase A2, when it's released, it's secreted. It will go to the mast cells and the eosinophils and cause them to increase their cellular level of phospholipase A2, which becomes arachidonic acid. And from arachidonic acid, we get leukotrienes manufactured and also prostaglandins, which also cause bronchoconstriction. So let's talk about what happens in the airways during exercise. The ventilatory rate increases to meet the oxygen requirements of both the muscles and the heart's a muscle. So you're going to be breathing deeper and faster, and it's not just the nose involved, it's also the mouth. This challenges the airway's ability to condition the air to the correct moisture and heat that will be acceptable at the alveolar level. And the inhalation of cold, dry air causes osmotic changes. We're losing water to the air from the airways. Thermal changes. We're losing heat to the air. Epithelial injury. As we're breathing deeper and faster, that's a lot of force coming through those lower airways, and it causes the epithelium to be disrupted or damaged. From the airway leakage of the vasculature, we get some inflammation occurring, and also there's nerve activation that's involved in this. Now let's talk about the challenge the airways face to condition the air to the proper heat and moisture level. So air needs to be heated and humidified to body conditions before entering the alveoli. All right, well, on the right, we're looking at blue box, and what we're looking at is the tracheal bronchial tree. The numbers on the far right indicate what generation we're at in the airways. So they keep splitting and splitting into smaller and smaller generations. So remember, this is going to be taking place, the exercise-induced bronchoconstriction and exercise-induced asthma involving the lower airways. So let's just talk first of all about resting ventilation and see how we work into this situation where we're involving the lower airways. Resting ventilation, we're moving on the average 6 liters per minute. Well, the nose can handle that volume of air. We don't have to involve the mouth. So the nasal mucosa, the turbinates and such inside the nose, condition the air to the proper moisture and the proper heat before it reaches the alveolus. How about now if we go to moderate hyperpnea or deeper breathing, like we'd start seeing with, a pretty moderate level of exercise. All of a sudden now we're up to 5 times the volume of air being moved. We're up to 30 liters per minute. Okay, the sol layer, that's part of the mucosal layer of the airway surface liquid, is involved as we're moving to the smaller airways, in that this sol layer of the mucus starts giving up its moisture to the drier air coming in and out. And what's happening at that point, and it's giving up its heat as well to the colder air. And what happens is the nose cannot handle that volume of air, so we've got to switch to mouth breathing as well as nose breathing. Well, the air that's going through the nose is still being conditioned, but when it comes through the mouth, we're moving down to the smaller generations of the airways, and we're relying on them to give up their moisture, the mucosal layer and the epithelium below it, give up their moisture and their heat to the air coming in. And that is a level of conditioning that they're not used to. So vigorous exercise now, we step up the speed of the air even more, and it's going deeper and deeper into the airways because the nose cannot handle that volume. We're up to 40 liters per minute. The smaller airways below the 12th generation that are really getting to be small airways now that we're getting into are starting to condition that air. And as I said, they're just not used to it. They're giving up their moisture, they're giving up their heat, and this is what ends up triggering this whole exercise-induced bronchoconstriction thing, that it's a trauma to those airways. And basically they're saying, we've got a problem. We're not used to conditioning this air. This next slide depicts an ongoing tug-of-war between the two camps. The osmosis camp that says it is dry air that causes this exercise-induced bronchoconstriction to take place, versus the thermal hypothesis camp that says no, it's colder air that causes it to happen. Well, if there are any amateur meteorologists in the audience, one thing we know, colder air is drier air. So maybe they're both right. So now let's take this down to a deeper level as we're considering the impact of this deeper breathing on the lower airways. So the results of this hyperpnea, let's give the osmosis hypothesis camp the floor first to state their case. So during exercise, you're breathing in drier air And what will it trigger? Well, first of all, one thing, whether or not you're asthmatic, when your patient starts exercising, the interleukin-13 level increases in the blood. As I said, regardless whether or not you're asthmatic. We've got to remember interleukin-13 is produced by mast cells, eosinophils, and T helper 2 cells. And what interleukin-13 does, it does a number of things, but two of the most important things it does, it causes goblet cells to produce more mucus, and it also causes hyperreactivity in the airway. But put that to the back of your head that always goes up regardless. And we're going to be retrieving that information as we go on. So what happens from this deeper breathing of the drier air? The epithelial cells begin to dehydrate. When they dehydrate from giving up their fluid, they shrink. This increases the level of intercellular calcium in the cell. Whenever calcium levels go up, it's a catalyst. Things start happening usually very quickly in cells. Well, one of the things that happens is intracellular signaling goes on. And this isn't really understood yet. There's a lot of research being done on this, but it stimulates the vagus nerve to release 2 cytokines, one of which is substance P. The other one is neurokinin A. These are released, and what they do, well, one of the things they do is they cause bronchial smooth muscle to constrict. Another thing they do is cause goblet cells to produce more mucus. And another impact that they have is they stimulate the mast cells, causing the mast cells to degranulate. From this degranulation, we get histamine released, which is another bronchoconstrictor, and we get heparin released from the mast cells, which causes the vasculature, the capillaries in the airways to become more permeable, so we get some leakage going on. As they become more permeable, the airway wall becomes more swollen. We're experiencing some edema now, along with the bronchoconstriction. So we're starting to get the beginnings both mast cells and eosinophils to start manufacturing leukotrienes and also prostaglandins. The way it does it, it increases the intracellular level of phospholipase A2, which turns into arachidonic acid. And from arachidonic acid, we manufacture our cysteinoleukotrienes and our prostaglandin D2. Now, the mast cells and the eosinophils, we know, also release the interleukin-13. Remember earlier I said, put that to the back of your head, we're going to retrieve it. Right now is when we're going to retrieve it. There is a good prostaglandin generated by the mast cells and eosinophils called prostaglandin E2, which actually is part of your body's feedback mechanism. It suppresses the action of the mast cells. So the mast cells don't degranulate and they don't produce more cysteinoleukotrienes when prostaglandin E2 is released. It basically tells the mast cells, cool it. Well, what's happening now is in asthmatics, for some reason, and this is still under study, interleukin-13 blocks that process whereby prostaglandin E2 is manufactured. So with prostaglandin E2 not coming in as a player, the mast cells can do whatever they want. They continue to degranulate, and they continue to do things like produce more prostaglandins that cause bronchoconstriction and also cysteinoleukotrienes. So it tips the scale. You've got this balance between cysteinoleukotrienes and prostaglandin E2. With fewer prostaglandin E2, the scale tips in favor more of a bronchoconstriction rather than bronchodilation. So what we have is the cysteinoleucotrienes that are manufactured and the prostaglandins cause more bronchoconstriction and mucus production in the goblet cells. So now that we outlined the process of the osmosis hypothesis, let's get a picture of it. Now, I've divided this into two slides, okay? This first slide, we're going to talk about the cell shrinkage and how the mast cells are activated. So what's happening here is, as we can see, there's increased ventilation of this drier air, and note the mucosal layer is losing its water to the dry air, and the epithelium below, the ciliated epithelium that we see, is donating its water, causing what? Dehydration of these cells. From the dehydration, as we talked about it, the calcium levels go up. This is a catalyst now. Things start happening in the cell, and we get the cell shrinkage and the intracellular signaling that still is not understood. But through this whole process, the afferent nerve of the vagus nerve gets stimulated. And because of that, it releases substance P and neurokinin A. What did we say about those earlier? They cause the goblet cells to produce more mucus. They cause a bronchoconstriction from the bronchial smooth muscle. And one of the big things they do is aggravate the mast cell, stimulate it, if you will, to release histamine and heparin. Histamine is another bronchoconstrictor, and the heparin, as we know, causes the vasculature in the airways, the capillaries and such, to leak. And because of this, we start getting the edema. So we're looking at bronchoconstriction. We're looking at some mucosal cell activation, the goblet cells, and we're also looking at the mast cells degranulation, driving more of that bronchoconstriction. So now let's talk about the second phase of this osmosis hypothesis. So what has happened now is we're taking another look, a little bit different picture, but it represents the same airway epithelium at the small airway level. And what's happening here is we're looking at the respiration of that dry air coming in, and it's stimulating or traumatizing, if you will, the ciliated epithelium that causes it to release phospholipase A2. This phospholipase A2 will be a stimulus to the eosinophils and to the mast cells. What's it do? It causes that cellular level to go up inside these two types of cells of the phospholipase A2, which in turn becomes arachidonic acid. And from arachidonic acid, we make leukotrienes and prostaglandins. Now, the cysteinoleucotrienes that are generated, notice here, they stimulate the sensory nerves. In the process of stimulating those sensory nerves of the vagus nerve, what happens? It causes the vagus nerve to release more neurokinin A and substance P, which causes the mast cells to degranulate. So we've got a reciprocating process that we talked about here going on. And the other thing the cysteinoleucotrienes do is cause the goblet cells to produce more mucus, and it causes bronchoconstriction by attaching to the leukotriene receptors on the bronchial smooth muscle. So we have the histamine causing the bronchoconstriction, the leukotrienes, and the neurokinins, and substance P. Notice the eosinophils and even the mast cells will generate interleukin-13. We said that goes up when anybody exercises, but and it will cause the goblet cells to produce more mucus, and It also makes the airways more hyperresponsive. One of the things that we said interleukin-13 will do is block the formation of prostaglandin E2. Remember what prostaglandin E2 does? It tells the mast cells to stop degranulating and stop producing leukotrienes. We're shutting off that process now. So again, we're moving toward more of a bronchoconstriction event than a bronchodilation event. So if we took this as a case into the courtroom, we would find that we're having fewer prostaglandin E2, more cystinoid leukotrienes, judgment for the side of bronchoconstriction. So a couple more quick things about the pathophysiology of EIB in asthmatics. We find that there are higher levels of columnar epithelium in the airway sputum than asthmatics without EIB. So there is definitely epithelial damage. Higher levels of a mucus MUC5AC gene expression. MUC5AC is a type of mucus released by the goblet cells when they get signals from the Clara cells or club cell as it's called. Remember, that has a defense mechanism that it releases the Clara cell secretory protein. It causes the goblet cells to produce more of this protective, if you will, mucus. And there's an implication of a mechanism where mucus release occurs from glucotriene production that mediates the activation of airway sensory nerves. Again, we're getting that reciprocating process. The airway nerves stimulate the eosinophils and the mast cells. The mast cells produce the leukotrienes that stimulates the nerves in the airways. Now, I'm not going to spend a lot of time on this slide. This is more of a granular level look at the cellular crosstalk that's taking place between the epithelial cells and the eosinophils when the epithelium releases the secreted phospholipase A2 and how it interacts with the eosinophils and also the mast cells to produce arachidonic acid, which we get our cystinoid leukotrienes and prostaglandins from. Now let's hear from the thermal hypothesis camp, which is basically saying the amount of bronchial narrowing that follows deep breathing depends on the thermal events in the airways. How much cooler is the air that's got to be warmed to body temperature? And that will lead to the degree of cooling that has to take place during an exercise challenge. And what we're looking at that is very, very important here is how quickly during the cool down process, when you've stopped exercising, that the airways rewarm. The magnitude and rate of airway rewarming plays an important role in exercise-induced asthma or exercise-induced bronchospasm. And cooling brought about by hyperpnea, as I said earlier, is followed by rewarming once hyperpnea ceases. So let's talk about the mechanism or process of the thermal hypothesis. So the deeper, faster breathing of air cools and dries the airways, which leads to vasoconstriction. It's like when you go outside in the winter without gloves, what happens? Your fingers go numb because your body causes the blood vessels in your fingers to vasoconstrict to conserve the heat. The same thing happens in the airways initially. So this stimulates the cholinergic nerves. The vagus nerve, when it returns, releases acetylcholine, which hits the muscarinic 3 receptors, causing mucus to be released from the goblet cells, more mucus, and it also causes bronchoconstriction. These are the same muscarinic receptors that we go after with methacholine when we're doing a challenge there. And it's the same ones we block with things like ipratropium and tiotropium. So this causes some bronchoconstriction and mucus release, but After exercise now, the airways start to warm up. The vasculature opens up and it gets engorged because the blood's backed up. Let's take a look at what the picture of this would look like. So let's get a picture of what this thermal hypothesis looks like. I've divided this into two slides. Slide 1, which is part 1, is the airway cooling. This is what's happening during exercise, okay? So the patient is breathing deeper and faster. This is colder air coming in and out, and we can see our mucosal layer is losing heat. The epithelium below is donating its heat up into the mucosal layer. And as we can look down, we see the blood vessels are also giving up their heat. Well, they constrict. See how the blood vessel has gotten smaller? And that's the vasoconstriction that is taking place in order to try to conserve the heat. This whole process, the trauma of this colder air causes the afferent vagus nerve to get stimulated, carries a message to the central nervous system, and the central nervous system sends back the message via the efferent vagus nerve that releases what? Acetylcholine, as we said. We can see its first stop is the bronchial smooth muscle, causing bronchial constriction, and also the muscarinic receptors get stimulated with the acetylcholine on the goblet cells, and the goblet cells produce more mucus. So we've got the first stage here of the airway narrowing during exercise. There is a little bit of bronchoconstriction going on, and there's also mucus being produced, which is going to narrow the airway. Now let's consider part 2. Exercise is stopped. Our patient has stopped running or whatever activity they're doing, and they're resuming nose breathing again now, allowing the airways to rewarm. Now, what's really important here is how quickly they go back to normal breathing. If it's over a period of time, then there's less a probability of this the second part happening. If it is immediate, though, that they're able to go back to normal breathing, that's going to cause a shock to the airways, and let's look at how it does that. The ventilation is reduced now, so we're not getting as much cold, dry air coming in, colder air mostly in this hypothesis. So what happens? The airways begin to rewarm. And when the airways rewarm, so do the capillaries and the other blood vessels in the airways. When they rewarm, they vasodilate. By opening up now, the blood starts coming in. Now remember, it was backed up for a while. We were conserving our heat. So what happens is this engorgement of the blood vessels causes some leakage, permeability, congestion, and the airways begin to narrow because of edema. This fluid is going into the airway wall. So we have the edema from the airways, we have the mucus secretions from when we were exercising, and we also have the bronchoconstriction, the mucus and the bronchoconstriction being from the release of the acetylcholine, the airway wall edema being from the engorgement of the blood vessels. Now, as though two hypotheses were not enough, we have a third party throwing their hat in the ring. Epithelial microtrauma hypothesis. This is one that we've noticed more with elite athletes that are training every day, but it's not just restricted to them. And the whole idea is this deeper, faster breathing. We're looking at the speed of the air moving in and out of the airways rapidly, causing this situation of not only dehydration, but sheer stress on those airways of that air moving in and out quickly. And what this causes from this increased airflow, a change in what we call the transepithelial pressure gradient. That's basically the pressure change needed to move the air in and out. So instead of just moving the air in and out slowly, as would occur when a person is just tidal breathing, we're talking about huffing and puffing like when someone is exercising. They're breathing much deeper and much faster, bringing that air in and out rapidly in those smaller airways, and it causes the epithelial damage or disruption. And this has got to be repaired by the lower cells, like the basal cells, uh, differentiating into them to replace those cells that were damaged. And the end result is bronchial hyperreactivity and airway remodeling. And this is a big factor in the epithelial microtrauma hypothesis, as we're going to see next. So let's get a picture of this. We're talking about the shear stress that is caused by the increase in the airflow. Our first picture here is just resting tidal breathing. So we're moving the air in and out, and there's not a lot of air movement, just enough to move the air in and out. And again, we're talking about the smaller airways. Look at our transepithelial pressure gradient to the right, only negative 8.5 centimeters of mercury. To the airways, that is a summer breeze moving the air in and out. No problem, no real stress on the airways. Now let's move down to our exercise breathing. So we're breathing deeper and faster. There's a lot more huffing and puffing of the air. What's happening is the shear stress level is going up much more. The shear stress of that air moving back and forth across the airways rapidly. Look at what's happened to our transepithelial pressure gradient on the right. It has moved up to negative 20 centimeters of mercury. That's almost 2.5 times of an increase. So this is no longer just a little summer breeze moving the air in and out of the airways. This is gale force winds moving in and out. And what happens is, look at our ciliated epithelium. It's shed into the airways. It's damaged. And the basal cells below have to move up. They have to differentiate into these ciliated epithelium in order to repair it. So repeated, going in and out, in and out. Yeah, we're seeing some damage there, and that's got to be replaced. That's the beginning of what starts happening during the microtrauma hypothesis. So from this, we get some airway remodeling occurring due to repetitive microtrauma of the airways, and it leads to hyperreactivity. Remember earlier we talked about interleukin-13 increased in everybody during exercise, whether or not you're asthmatic. Well, the microtrauma and that stimulates the epithelium to release some interleukin-8. Interleukin-8 is another cytokine, and it is a bug light for neutrophils. And it also, the interleukin-13, as we said, induces goblet cells to release more mucus. Now, these neutrophils arrive, okay, through diapedesis crossing the capillaries, and it induces the Clara cells to release their Clara cell secretory protein. Remember, that protects the body, and it basically shuts down the border and says no more neutrophils come in. However, the ones that arrived cause their damage. They release things like reactive oxygen species, which damages the airways. And secondly, what it does, it causes the Clara cells, the neutrophils cause the Clara cells to transform into goblet cells. Here's where the remodeling takes place. It's believed that releasing something called tumor necrosis factor alpha, that's another cytokine released by the neutrophils that causes this transformation of the Clara cells into goblet cells. So what happens is, from the shear stress, as you're going to see in the next slide, we get airway remodeling. Now let's look at our picture here, what's going on. So the shear stress is taken out a lot of the ciliated epithelium, and we said that the tumor necrosis factor was released by the neutrophils. And what has happened? Our Clara cells and also our basal cells are progenitors. They differentiate into other cells, especially the basal cells. So what's happened is they differentiate into the goblet cells. You're getting more goblet cells in the airways, and more goblet cells are going to produce more mucus. So there's the mucus buildup. We have fewer and fewer ciliated epithelium to move that mucosal layer along. So what happens? The mucus accumulates in the airways. It's not moving as rapidly, and we've got more cells producing more of it. The result, if we look at our airway to the right here, it's more narrowed due to mucus accumulation in that airway. That is the remodeling that takes place. Again, we see a lot of this in elite athletes that are doing their repetitive exercise out there, breathing deep and fast, and it's repetitive damage to these lower airways that is causing this condition. Okay, that was a lot of pathophysiology. Let's move next to our next section, which is the actual diagnosing of exercise-induced bronchoconstriction. As we can see, symptoms alone are not going to be enough to determine if your patient has EIB. So what we can do, one of the things is spirometry, pre and post bronchodilator, to detect if there's some underlying asthma, especially if the patient comes in obstructed and we see a large change when we do spirometry before and after. This may be a good clue, because what do we know? If they have asthma, there's a 75 to 80% chance that exercise is a trigger. Therefore, they have a good chance of having exercise-induced bronchoconstriction. But are there some tests that are specific just to exercise-induced bronchoconstriction? Yes. One of the main ones is our gold standard, as we call it, spirometry pre and post exercise challenge test. And this is an indirect EIB test, in that we're going down to the level that we're trying to actually produce the conditions that cause this. We can do it on a treadmill or on the exercise cycle ergometer, the bike. We're going to be measuring the spirometry 5, 10, 15, 20, and 30 minutes post-challenge. And we're looking for a greater than 10% drop in the forced expiratory volume post-exercise. That would be considered a positive test. Remember, the forced expiratory volume is after your patient has taken a deep breath in when you're doing spirometry, the amount of air they could forcefully exhale out in the first second. What are alternatives to this that we're going to be looking at? Well, we're not going to actually look at a methacholine challenge, but we know that from speaking before with cold weather athletes, this is another test that could be done, and it's more of a direct test because it's going at the muscarinic receptors. It's a direct test. Mannitol challenge, on the other hand, is an indirect test, because what we're doing is we're looking more at the drying of the airways, or the osmosis theory. And that's what we're driving with the mannitol challenges we're going to see. There's also the eucapnic voluntary hyperventilation, another indirect test that we're going to look at, whereby we're doing the challenge, having them breathe deep and fast without actually doing the exercise. And listed here for just completion's sake is the hypertonic saline challenge, dry air challenge, cold air challenge, and histamine challenges. What preparations do we have to make for an exercise challenge test? Well, they're going to be holding their breathing medications, caffeine, and no cigarette smoking on the day of the test. No exercise on the day of the test. Pre-spirometry is performed. We use nose clips to make sure they're breathing through their mouth, help dry out the airways. Some labs will use a full face mask with medically dry air. And as I said, the air should be dry anyway. Water content less than 10 milligrams of water per liter of air. And we monitor their EKG, their pulse oximetry, and blood pressure throughout the test. Let's talk about the treadmill exercise challenge first. We're going to use the belt speed and the grade of the treadmill to get them to their desired ventilatory rate and heart rates. And we've got to do that within 4 minutes. If we go beyond 4 minutes to get them to that heart rate and ventilatory rate we want them at, their airways have time to acclimate, and we have a chance of getting a false negative on our exercise challenge. We're shooting for a minute ventilation of 40 to 60% of their maximum voluntary ventilation. That is hyperventilating for 1 minute. How much air would you move? We want you to reach 40 to 60% of that maximum within 4 minutes to make sure we dry or cool those airways out. We also want the heart rate to be 89 to 90% of your maximum predicted heart rate. Once we get you there within 4 minutes, we want to hold your patient there for 4 to 6 minutes. And then what we do is post-exercise 5, 10, 15, and 20 minutes post-exercise, also 30 minutes. And we're looking for our greatest decreases usually within 10 to 15 minutes post-exercise. And this is what our treadmill challenge looks like. Basically, the patient is on that treadmill, nose clips on. They're breathing through the mouthpiece there, which is measuring their respiratory rate to make sure we get them to their desired minute ventilation, 40 to 60% of their maximum voluntary ventilation in 4 minutes. Sustain it for 4 minutes to 6 minutes. And what we want to do is our spirometry post 5, 10, 15, 20, and 30 minutes. What about the bike ergometer? This is a little bit harder. Okay, you don't go into warm up, you go directly into exercise. And here's an equation we use for predicted wattage. Wattage is what we're going to use. That's a measure of work or power. The greater the wattage, the harder it is to pedal the bike. That's what we're going to use because we don't have speed and grade to try to make it harder that they're breathing heavier. Here's the predicted watts. This is an equation from the American Thoracic Society, and it's based on their FEV1 derived from spirometry. And basically what we're looking at, this is kind of like a ballpark because where do we start them to get them up to this desired heart rate and minute ventilation within 4 minutes? So as you could see, we come up with a predicted wattage, a maximum wattage, and we go 60% of that maximum wattage within the first minute of pedaling, 75% in the second, 90 in the third, and the maximum amount by the fourth minute. Now, this again is a ballpark. Suppose your patient gets to their maximum voluntary ventilation when you're only at 75%. Keep them there for 4 to 6 minutes and do your spirometry afterwards. You may even have to increase more than the predicted watts depending on your patient. And this is what it looks like on the exercise ergometer. Again, the nose clips on, breathing air that is dry, hopefully in the lab, or they would put in medically dry air. And again, there's our predicted formula. Within 4 minutes of beginning exercise, we want that minute ventilation up to 40 to 60% of the MVV. We want to sustain for 4 minutes to 6 minutes, and we do spirometry post 5, 10, 15, 20, and 30 minutes. So what about eucapnic voluntary hyperventilation? That's a mouthful. What it does is it mimics hyperventilation during exercise, cooling and drying the smaller airways without exercising. Pretest spirometry is performed just like with the exercise. Then the patient rapidly inhales and exhales for 6 minutes to dry out the airways. Now, how in the world do you do that without passing out? What we've got to do is alter the gas mixture a little bit. Right now, what you're breathing, it only contains about just under 1% of carbon dioxide. So we're going to give you 5% carbon dioxide with the same level of oxygen that you're normally breathing now and the balanced nitrogen. We keep the carbon dioxide level up in your blood because it's a vasodilator. If your blood vessels constrict when you blow too much of that off, that's why you pass out. So by going up to a 5% concentration, the patient can safely hyperventilate for 6 minutes, and then we do our post-spirometry 5, 10, 15, 20, and 30 minutes post-exercise, and a 10% or greater decrease in the FEV1 from baseline is a positive test. So this is what our eucapnic voluntary hyperventilation setup would look like. Here's our special gas over here, high in carbon dioxide. It goes through 6 here, as it says, a rotometer. And it fills, they say, a meteorological balloon. You could use a Douglas bag just as easy, and through a regulator over to the patient. Now let's talk about the mannitol challenge. It is a sugar alcohol, and it has a drying effect on the airway. So what we're trying to mimic here is the osmosis hypothesis, the loss of water causing this situation. It's dispensed as dry powdered inhalers at increasing dosages. So spirometry is performed to obtain a baseline. And then we start with the lowest dose possible of Aerodol. Patient breathes it in, waits 60 seconds, and does spirometry. And this continues up to the top concentration. A positive test is a 15% reduction in the forced expiratory volume from baseline, or a 10% reduction with consecutive dosages. So we're looking for a 10% reduction in the FEV1. That's considered a positive test. Let's discuss how to manage EIB and EIA. We're used to telling asthmatics to try to avoid their triggers. Well, we don't want to tell them to try to avoid exercise because we do want them to stay active. And as you could see here, physical activities have been proven to improve in asthmatics their forced expiratory volume in 1 second, their vital capacity, their peak flow. It also helps reduce symptoms and improve their quality of life. Now, there's two that we break it down into: non-pharmacologic interventions, exercise modification, diet, and special modifications tailored to the patient's activity, and pharmacological interventions. So let's talk about what modifications we could make to exercise to help not have to deal with exercise-induced bronchoconstriction. Remember when we were doing the exercise challenge, we had to make sure that we got our patients up to a certain respiratory rate and heart rate within 4 minutes. Otherwise, the body had time to acclimate. Well, what we're dealing with here is that is good news for us, because what we can do is have our patients get to the athletic field or the gym or the court 10 minutes early and take a few slow laps for 5 minutes. That'll cause the airways to acclimate, and in the process will drive down the possibility of them getting exercise-induced bronchoconstriction, because the airways have acclimated. And once they acclimate, they become very refractory to it. The other thing, remember when we were talking about the cold weather athletes coming down from their activities quickly and soon resuming nose breathing? Well, part of the problem with this is we ran into engorgement because the airways the airways, especially the vasculature, quickly rewarmed. Well, how about if we come down from our activity slowly and take a while to resume back to just nose breathing? That will allow it to happen over time, and we won't get as much engorgement possibly. So those are two things that we could use to modify our exercise. So now let's consider the role that diet plays in trying to prevent exercise-induced asthma and exercise-induced bronchoconstriction. One thing we know from studies is that gut microbiota plays a key role in the immune response to diet in asthma. So anything that's going to bring on inflammation, what do we know that really promotes inflammation? Sugars and fats. They push the gut microbiota into a pattern that it favors inflammation. And inflammation, as we know, is going to start bringing on the eosinophil growth. And we know what we're going to get from the eosinophils, the leukotrienes and such things as that. One thing we know from studies, though, fruit. I know we think of fruit as being high in sugar, but fruit has been studied over and over, and a higher fruit diet helps reduce inflammation. It boosts the body's immune system. We know that from studies. They've done studies on both fruit and vegetables, but it seems like fruit always comes out on top on these studies, that it really does a great job at helping reduce inflammation. There was a study done on salt, and what they were looking at was a low salt diet. So each subject was in this longitudinal study, each subject was either a control for a while in that they were on a normal salt diet. Then for a while, each one was on a low salt diet and a high salt diet. And this was the results of the studies. The low salt diet was found to increase the diffusion, the DLCO. That's the pulmonary function test that tells us how well the oxygen is getting into the blood. That increased on a low salt diet over a normal salt diet and a high salt diet. Also, there was decreased capillary blood volume. And this would be an important factor when we're considering the engorgement that happens afterwards after exercise, especially in cold air. So there's some benefit to reducing the amount of salt these people are taking in that are experiencing exercise-induced bronchoconstriction. Another thing, fish oil may have an anti-inflammatory effect. And the other thing with diet, caffeine does have a mild bronchodilator effect. One more thing we can consider. So as our last non-pharmacologic intervention, let's consider special modifications the patient can make tailored to their activity. Face masks are a good idea, especially if colder or drier air is one of their triggers for this. By using a face mask, it will serve as a heat moisture exchanger. So it's slowing down the heat loss, and it's also conserving the moisture because it serves as a reservoir. Another thing it can do is reduce the amount of inhaled allergens or irritants that your patient is breathing in while they're exercising. Secondly, they can choose a better environment for their activity. So if they are in cities, your patient lives in a city, they don't want to go jogging or biking near a freeway. If those irritants and pollutants from the cars are a problem for their as a trigger for their asthma, you don't want to go jogging and working out in those areas anyway, even if you're not asthmatic. Another thing you could do is check the pollution alerts on the radio and also the pollen alerts. If pollen is a trigger, perhaps you want to do your exercise in the morning when there's still dew on the grass. These are the various things you should consider for your patient if these things are a trigger for their exercise-induced bronchoconstriction. What pharmacological interventions can we use? Well, Global Initiative for Asthma recommends reliever medications and inhaled corticosteroids. Sometimes there are breakthrough symptoms, and warming up prior to exercise, we already talked about, that's a good thing to do. Short-acting beta agonists or low-dose inhaled corticosteroid formoterol combination before exercise is a good idea. Some patients will get relief from inhaled corticosteroids combined with long-acting beta agonists. Patients that cannot take beta agonists may benefit from muscarinic antagonists. We saw this with the muscarinic receptors, especially in cold weather athletes, and the leukotriene receptor antagonists may also be beneficial, such as montelukast. These are my references. Finally, we're back to our hypothesis tug of war. Is it osmosis, is it thermal, or is it microtrauma? Well, folks, remember, it is a heterogeneous disease we're dealing with, and maybe, just maybe, many roads lead to Rome. It could be a combination of all three.